Well, we're going to take this a little lighthearted. I represent a vendor. I'm a general surgeon and been involved in electronic medical records for about 20 years, both in practice as well as helping design and develop in a couple different applications over the years. Believe me, I stand here a little humbled because everything you've said so far is absolutely correct. But I want you to understand from the vendor's perspective, and I know Toby's here, and a couple other, David's here. We, from the vendor side, have worked extremely hard to try to provide an application that's useful to my colleagues and users. The frustration over the years has been that it's a moving target. Technology changes, and what I'm going to try to do is just talk a little bit about our problems as a collective group of both trying to solve the issue of usability and functionality within an application. Now, in my world, I kind of look at a couple things. It's kind of a situation that we've all seen as parents. You know, been in a car trip. Dad, are we there yet? Well, I kind of equate this into my development team is year after year, they ask me kind of, are we there yet? And I say, we're 50% there. The comment says, well, you said that last year. I said, I'm going to say it next year. Because that's where we are. I mean, things are changing dramatically in our world, have been changing for the 20 years I've been involved with it. I look back as a user before and say, you know, I've functioned as a user. Was it perfect? No. Is it perfect now? No. And we understand that. With the help of a lot of folks in this room, we can kind of move forward on this. But I do want to say my perspective here today is really ambulatory. I'm not talking about inpatient care. 77% of the physicians surveyed by Jackson Healthcare survey here last year are ambulatory physicians, work in that ambulatory environment. And that's where our focus is in the company I represent. So I'm going to speak specifically about that. First thing that's been a real challenge is that, you know, it's like a Ferrari. EHRs are similar to a Ferrari, okay? They're costly. They're costly, they're expensive, and not everybody can fit into them, okay? Including myself. So how do we make it, you know, we don't want to get to the point of a school bus where everybody fits into it. We want to have a model that's efficient, fast, sporty, whatever it needs to be to get where we need to get. So when I look at this whole process, I start thinking about, you know, the infrastructure. Looking at private practice situations specifically and how we handle the infrastructure. When we first started in my company in Greenway, we had to become the de facto IT company for practices. We had to teach them about networking. We had to teach them about communications. And that wasn't really our forte. We were trying to build a software system that worked in those environments. The hardware situation changed dramatically over the years. So to speak, called with form factors, as I've been told, is our terminology now. We get into situations like we primarily in one operating system, and now a very retail version comes out, and people are excited about the iPad. How do we get that operating system in this world? When it's really designed to be a consumer product, how do we make it a product that can be thrown across an exam room? So we've had the challenges with both communications, hardware, networking, and all that. But on the future, we see a different horizon. We see the cloud-based environment. And that is going to be a big plus, especially in disaster recovery situations where a lot of clinics are. We had 28 clinics at risk during Katrina, for instance. And one guy showed up on our doorsteps with a Buffalo Drive hard drive with all his data in there, ready to go. Those days are over. We're going to really use that in a model of the cloud-based security and disaster recovery. When we look at the next thing that really gets into my understanding of the problems is clinical workflow. When I was in surgical residency years ago, it used to be a common statement. One professor would say, you know, when we're doing a procedure, we do it the same way every time. Then my chief resident would walk out the door, yeah, only different. And that's kind of the way it is in electronic health records. You know, you go in and you survey a bunch of physicians, And what happens? Oh, we do it the same way every time. And then you get into a clinical environment and things change dramatically. And how flexible can we get? We have to be flexible in order to obtain and to accommodate those a variety of workflows. But at the same time, what you're trying to do is rein all those crazy workflows into some logical pattern that you can do in a software and make that practice more efficient and compliant. And we have a lot of conflict with those. And a good example in this workflow thing was just told to me about 3 weeks ago when I was at a regional meeting for Greenway. And one of our regional sales managers told me, he says, I got to tell you this story. And I'm sorry we haven't done this study before internally, but this is a good example of EHR usability in ambulatory. He says, I've got 2 practices in my area. Both went live within a week of each other. Both are OBGYN. They're almost identical in size and formation, how they handle their practices, yet we've had 2 different outcomes over a 9-month period of how the practice is done. One's done extremely well with our system, and one hasn't done so well. So how do you handle this stuff? I mean, you can say it's usability, but obviously there's some other factors involved in this thing, you know? So where it comes, the other factors potentially could be, which is a common thing, is the physicians, the administrators, the people within the practice themselves. And that's the challenge we have as a company, that we have a variety of things to try to help train and teach people. But the old adage, you can lead them to water, but you can't make them drink. The mindset within a practice of how successful they want to be makes a big difference on their usability and success rate. You know, I agree with you. There are definitely design features and things that we're trying to improve all the time and make a difference. Some are internal factors that we can change, and sometimes they're external factors. For instance, we brought up this one comment about medication reconciliation. Well, a very easy situation now is in an EHR is to go out to a company like SureScripts and pull down the PBM, the medication history. Well, what's the problem with that? One of the problems is they only provide medications were purchased through a drug card. If the patient purchases it by cash, it's not recorded. And the information we get is not the full SIG or the script. What we get is the dosage and the number of pills. Doesn't tell me how it's taken. So that's an inherent problem that is external to a system like ours, where you're trying to help with medication reconciliation, but we have a encumberment upon the connection between 2 vendors. So things like that are outside our environment, but still we're impacted as well as obviously the user is. The issues in dealing with practices and trying to educate, we provide a lot of different opportunities to educate practices. And one of the things we find in ambulatory world is that the cost of training is not well received by a lot of the practices. That's where they look at it as a cost savings when they purchase an electronic health record. Penny wise, pound foolish. The ones that are successful enjoying the training and that and understand where they can get up to speed quicker on this. So the things that, those are a couple of the infrastructure part of it. The workflow issue is a big challenge for vendors like us. There's definitely an issue with clicking. We understand that. We work very hard on trying to get the point and click, but we got 4 options in data entry in electronic medical records. Handwriting recognition, typing, point and click, and voice. None of them are perfect. And what we're looking at as a future, though, is moving along, and I've been working now for about 3 or 4 years on a speech recognition model that it really ends up not being speech to text, but speech to text to XML. Once we can pull that XML document into our system, it opens up the whole door to being able to extract information, import information from that, run rules engines through it, runs alerts such as E&M coding engines, alerts and reminders engines. It changes the whole world dramatically in the sense that you now allow a user to say things that they want to say and yet be able to extract information out into this world. So that is one of our future options here. Other part of the areas we work in is really trying to get vocabulary model established. Years ago, when SNOMED was kind of the chosen as particular vocabulary model to use, everyone understands that it's relatively difficult to use at the point of care. So we've been working with interface terminology over the last several years to try to provide clinically friendly terms that are codified that we can then put into a database and extract information out, and especially when it comes down to clinical decision support and patient safety factors. That's one thing I think that's really lagged behind in our country, the ability to really do that well. And believe it or not, I'm a big proponent of moving towards ICD-10 just because it pushes the envelope to force more granularity in our diagnosis, more granularity in a lot of our concepts within an EHR, codified, be able to extract that from a database and be able to do things that are truly meaningful in quality measures. So those are some of the things that we're looking at in the future. I think clinical decision support is a huge factor of that, and I think most of us who understand clinical decision support knows that we've got to have good information within a system in order to extract good information out and alert patients and all that. A future thing that we're heavily involved with now is obviously care coordination. Big factor, being able to exchange information, interoperability. We, as an ambulatory company, have worked with several of the large hospital vendors to provide interoperative connections, not just interfaces, but really moving towards trying to provide information back and forth between the systems and to allow practitioners to stay in an environment they're comfortable with. So from my perspective, usability is changing. It's an ever-changing model. I appreciate all the efforts that we've tried to accomplish over the last 4 years and look forward to some of the things that are coming forward to us. And certainly from our perspective, we embrace enhancing the usability. We understand it's ever-changing. Someday we'll get there, but Dad, we're not there yet. Thank you.